Welcome to Pharm Mini number 14, Antiviral Medications. Antiviral medications alter viral reproduction. Because it alters viral reproduction, when a virus is dormant and not reproducing, these medications may be ineffective. It can also prevent HIV from entering certain cells, and we'll talk about the HIV antiretroviral medications, but the specific categories of those that prevent the HIV from entering cell walls include the fusion and entry inhibitors, as well as the CCR5 antagonist. It can also inhibit enzymes that are used for HIV replication, and that would include our NTRIs, our NNTRIs, our PIs, and our INSTIs. So overall, antiviral medications are used to treat any virus infections, and those we would call antivirals, or to treat HIV, which we would call an antiretroviral. With the antiretroviral medications, we can combine 3 or more to work on different phases of the HIV virus and to reduce levels of the virus in the CD4. When we have that combination, we call it HART therapy, or highly active antiretroviral therapy. And this is very effective in reducing those CD4 and viral levels within 6 months. So if patients are taking these medications, they can live a more full life with limited symptoms than we were able to provide 20, 40 years ago. Some examples of antiviral medications include medications that end in VIR. So remember, antiviral treats any viruses. So this could be acyclovir, ganacyclovir, teleprevir, boceprevir, ribavirin, oseltamivir, lamivudine, and interferon alpha 2B. Side effects of our antiviral medications include phlebitis, nausea, headaches, diarrhea, and fever. Adverse effects would be nephrotoxicity and bone marrow suppression. Antiviral medications do interact with cytotoxic medications, zidovudine, which is an antiretroviral medication, and probenecid. Contraindications would be renal impairment and dehydration, used with caution with pregnancy and lactation, and neutropenia. Nursing considerations and education is if someone is receiving an antiviral medication, it should be taken with food. It can be administered PO, IV, or topical. If given IV, it does need to be administered slowly. We should wear gloves when administering, and we'd want to encourage fluids in our patients. Then we have our antiretroviral classes of medications. So as I mentioned, we have our fusion and entry inhibitors. This is an example of efavirenz, which is given through a subcutaneous injection. We have our CCR5 antagonist, or Maraviric, which is given orally. Our NRTIs are given orally or IV, and these ones end in udine. The most common one that we see is zidovudine. We have our NNRTs, which are given orally, and these end in viridine, such as delavirdine and entraviridine. We have our protease inhibitors, or our PIs, which are given orally, and these also end in navar. So this can be confusing with our antiviral medications that end in VIR, but these ones specifically end in NAVIR. And then we have our INSTIs, such as ralgutafar, which is given orally. As far as side effects of these antiretroviral medications go, it can cause injection site irritation, fever and chills, rashes, hypotension, CNS effects, nausea, vomiting, and diarrhea, bone loss, hyperglycemia, high cholesterol, and insomnia. For our adverse reactions of the fusion and entry antiviral medications, it can cause bacterial pneumonia. For our CCR5s, it can cause upper respiratory tract infections, colitis, and hepatotoxicity. Our NTRIs can cause bone marrow suppression, lactic acidosis, and hepatomegaly. Because it does cause that bone marrow suppression, they're at even more risk for infection of other organisms, and they would need to be on neutropenic precautions and have their blood cells monitored. And then the INSTIs can cause suicidal ideation. As far as interactions go, a lot of these medications could interact with each other. So for example, CCR5 can interact with a protease inhibitor. More specifically, CCR5s and many antiviral medications interact, as well as with anticonvulsants, antifungals, antibiotics, and St. John's wort. NRTIs interact with valproic acid, methadone, ganciclovir, clarithromycin, and phenytoin. Our NNRTIs interact with antacids, benzodiazepines, antihistamines, calcium channel blockers, warfarin, rifampin, and phenytoin. Our protease inhibitors interact with a wide variety of medications, but also interact with St. John's wort and grapefruit juice. So we would want to encourage our patients not to be drinking any grapefruit juice or eating any grapefruit. Our INSTIs include rifampin and tirapanvir. Contraindications of our fusion and entries would be breastfeeding. Our CCR5s would be liver and renal impairment, cardiovascular disorders, and hypotension. Our NRTIs would be pregnancy, neutropenic, so anyone that has low white blood cells, and liver disease. Our NNTRIs would be pregnancy, liver or renal disease. And then our protease inhibitors should not be given in anyone with liver disease, pancreatitis, diabetes, AV heart block, high cholesterol, or pregnancy. As far as nursing considerations go, as if we are giving it IM, we would want to rotate injection sites, and they may need the blood monitoring for some of those adverse reactions and side effects. And that wraps up our medication on antiviral and antiretroviral medications.